Good afternoon, everyone. I thank AOS and the scientific committee for giving me this opportunity. So we are here to discuss how to optimize the outcome of cataract surgery in uveitis. So we all know uveitic cataract is one of the common complications of uveitis. So they may be because of uncontrolled, unsustained inflammation or because of the treatment as such, like use of high dose and long duration of steroids in these patients. So the moment a surgeon looks at a uveitic cataract, the first thing that comes to his mind is a surgically demanding procedure. But for a uveitic person, the first thing that comes to his mind is how am I going to control the inflammation preoperatively and postoperatively. So unless due diligence is given to control of inflammation in perioperative period, even in a surgically good hand, these patients are going to have a disastrous postoperative period. So the outcome of the surgery is going to depend on the case selection, pre-op evaluation, pre-op management, intra-op management, and post-op complication. So as we said earlier, the first point is case selection. So we have two categories of patients. So one is visually significant cataract with well-controlled inflammation. In these patients, you can actually expect a good visual outcome, but you have another category. These are patients who have cataract impairing posterior segment. So these patients may have a posterior segment pathology. Here we are operating mainly to see what's happening in the posterior segment. So it's more of a therapeutic surgery than for a visual outcome. And again, we have few factors that has to be considered to optimize our outcome. One is the type of uveitis, that is uveitic diagnosis, and the response of the patient to the standard therapy so far. So what was the clinical course? Then you have 3 months of quiescence. So that is a standard rule which you don't want to break at any point, because you will suffer at maybe post-operatively when the inflammation is very bad. And always look for concomitant ocular pathology like optic nerve involvement and macular involvement. So as we said earlier, management is different in different type of uveitis. For example, we have Fuchs uveitis. These are patients who have good postoperative outcome. So you need not even wait for 3 months. So usually we say Fuchs and lepto, you need not wait for 3 months of quiescence. You usually get a very good postoperative outcome. The most common complication is vitreous opacification, and if it is progressive, you can go ahead and do cataracts, do pars plana vitrectomy in this patient. But on the other arm, you have juvenile idiopathic arthritis. These are children who present to us late because of white eye uveitis. So when they present to us, usually they have complications like cataract or band-shaped keratopathy. But you have to have a balance as to wait for a zero control of inflammation and cataract surgery, because these children are in their amblyogenic age. And even worse down the spectrum, you have Behçet's disease. Even after 6 months of quiescence, these patients may have poor visual outcome because they have concomitant co-pathologies like optic nerve involvement. And other diseases like VKH and SO, if you have periocular control of perioperative control of inflammation, usually the visual prognosis is very good. So coming to investigation, apart from your routine investigations like A scan, these patients may need additional investigation. For example, UBM to look at the ciliary body and zonules and posterior capsule. For example, if a patient had an intravitreal injection in the past and maybe a lens stitch. So in these cases, you would like to do a UBM to see the posterior capsular status before taking him for a surgery. And again, ultrasound will help to look at the posterior segment if the cataract is very dense, and OCT will help to look at the macular thickness, edema, and epiretinal membrane before posting these patients for surgery. This is the main part, preoperative medication. The first and foremost is steroids. So the dosage of the steroid in the pre and postoperative period will depend mainly on the type of uveitis and the course of the patient with the disease so far. And again, you can go for intraoperative steroids also. It can be subconjunctival, intracameral, or intravitreal, but this will depend on the tissue handling and the anatomical location of the disease to begin with. Then if the patient is a patient with non-infectious uveitis and on immunosuppressive, you can continue your immunosuppressive. But if it is an infectious uveitis patient and you have treated it, for example, it's a case of herpes zoster ophthalmicus, you have to restart your antiviral treatment 3 weeks before surgery. So coming to intraoperative management, it's mainly the pupillary management which is different from rest of your cataract surgery. If you see, most of our patients have posterior synechiae and a small pupil. So this is a small video which will tell you how to manage a patient with small pupil. So you can introduce a cyclospatula through a side port made in a quadrant opposite to the posterior synechiae and sweep it across to break the synechiae between the iris and the anterior lens capsule. This pupil can be further stretched manually using 2 Hoagland's hooks. You can push the iris in the horizontal and vertical meridian 180-degree apart to stretch the pupil. But like in this patient, if the pupil is thin and atrophic, if you try to do a manual stretching, it may cause ripping of the iris. So in those cases, you have to go for self-retaining iris hooks. So usually we use self-retaining iris hooks through subparacentesis side ports, and we use 4 iris hooks. If needed, you can add one more iris hook just below the incision of your routine corneal incision, and you can see a diamond pattern of the dilatation. Next, recently we have pupil expanders. Actually, these are silicon material, and because of the material, it causes less inflammation and irritation to the iris. And again, this stretches the pupil in a circular manner and causes less stress to the iris. This can actually be introduced through a routine 2.2 corneal incision. Next, you have capsular management. You have to go for a larger excess, a minimum of 5 millimeter excess, because these patients are more prone for capsular phimosis in the longer run. The rest of the surgery can actually be continued as you do in any of the routine cataract surgery. Then you have IOL types. Hydrophobic acrylic IOLs are found to be biocompatible in these patients because they cause less of post-op inflammation and posterior capsular opacification. So always the rule is place the IOL in the bag. Even if it is a 3-piece IOL, don't place it in sulcus because it can further worsen the inflammation by irritating the iris continuously. So placing in the bag IOL is the thumb rule in uveitic cataracts. Post-op complications, it may be either early complication or a late complication. Early complication, the first one is excessive post-operative inflammation. So this may be either because of your tissue handling during the surgery or because of the disease as such. These may cause posterior synechiae and IOL capture. The other common complication is cystoid macular edema. This can be treated with difluprednate with NSAIDs. If it is still persisting, then you can go for periocular steroids in this patient. Again, always look for raised IOP or hypotony in these patients because of excessive inflammation. Late complication, these patients are again prone for posterior capsular opacification, but do not attempt NDR capsulotomy because the chance of retinal tear is very high, and wait for 6 months before you are planning a NDR cap. Capsular phimosis, as we said earlier, if you have done a large rexis, usually there won't be cocooning of the capsule. But if the patient had developed one, then you can give relaxing radial incisions to reduce the cocooning. So the take-home message here is period of documented quiescence. No, sometimes even the patient will say, inflammation is right now under control, I would like to go for a surgery. But then at the end of the surgery, it will be you who will be in the suffering phase. So always wait for 3 months, except for fuchs or in a leptocataract. Optimization of immunosuppression in the perioperative period. Avoid topical anesthesia because there may be a surgical surprise on the table. So avoid topical anesthesia. In the back, monofocal IOL is the thumb rule. Expect the unexpected, and surgery is not the end here. Always look for post-op complication and act proactively so that we can optimize the outcome in these patients. Thank you.